Hi, everyone. Can everyone hear me in the back? Yes? Cool. Okay. So it's wonderful to be here. I'm feeling very distracted by this big picture of me next to me. Very, very distracted. Okay, yes, thank you. So we're going to share gears a little bit. I want to talk about the importance of really engaging communities and families in the work we do, from kind of both, not just from a scientific perspective, which obviously is critical because we want to advance the science and find better treatments, as we've been hearing all day, but also because it's the right thing to do. And we also learn a lot. It seems for all the families here that we do have a lot to learn from you. So I think it's very, very important to include those voices. Can we go to the next slide? Oh, sorry, I'm not following instructions. Yeah, I was supposed to be doing this. So we're going to talk about why diversity is important. I'm going to share a framework that we've been using, and we'll share one tiny little story about work that we did when I was at the Seaver Center, and I've continued to do now, and something that is informing some of the other projects we've been doing. So, as we've been hearing, genomics and genetics are very important. It really has promised this idea of personalized approach to medicine. It is important to include populations from diverse ancestry into genomic studies, not just because we want to reach as many people as we can, but because it's very important to learn from the genomics and the genetics from populations that come from non-European descent. As the science has been advancing in other fields in medicine that are able to use this information in more in clinical care, in day-to-day clinical care, like what we are seeing here today is very exciting, but we're also learning that we're doing a lot of research with this. We want to kind of be one step ahead, and we know from research in other areas, oncological research, research in diabetes or cardiomyopathy, that by not including populations from diverse ancestry into genomic studies, we are creating a new generation of healthcare disparities, but we are also missing a lot of opportunities to learn about how the environment interacts with genes, to identify specific genes that might be more prevalent in certain populations, and to really come up with scores, for example, polygenic risk scores, which is 23andMe says that we can use them clinically, but truly we are not there yet. But the idea is that you can look at certain populations and look how these different tiny little common genetic variations could add and predict what is the likelihood that someone might have risk for a disorder. And that is important because then you can also incorporate things that will help you prevent, that you might be more, you might make decisions a little bit differently. The other part of this is, as we are understanding social inequity, we will be able to study kind of social determinants of health in a way that might be very difficult to do if you are only focusing on one particular population. However, as we know, this is extremely important, and this is during the years where everybody was really investing in increasing diversity in research for a number of reasons, not just scientific. We've really had a really hard time making these data sets of more, to include populations that are not wholly or mostly of European descent. So in 2009, most of the studies included, like 96% of the data sets were of populations of European descent. And it got better in 2016. There was a lot of excitement and investment, and I think people started to think about these ways, not just from a scientific perspective, but also in the sense in which it actually kind of helps everyone from other reasons. However, even with those efforts, the rates came down. So in 2021, it was actually the percentage. We continued to collect all of these samples, but the percentage in comparison, so we had more samples, let's say, from Africa or Latin America or South Asia, However, the percentage in comparison to everything else was still smaller. So it really kind of didn't solve much of the issue. So why is this happening? It's very different to go to a community that has a lot of resources or to work with communities that are actually coming to you and saying, hey, I heard you're doing this really cool work. Can I be part of it? To go to places where families are really struggling to access the most basic things, like a diagnosis. Forget about genetics, right? Buying food. And many of the populations that belong to these groups that we would want to expand to generate more diversity are communities that are under-resourced. The other part of it is even when they are not under-resourced, unfortunately, scientists have made a lot of poor decisions in the past in the name of science, and there's a lot of distrust. So creating the infrastructure, building the relationships, and kind of understanding the different cultures takes time, money, and effort. The other part of it is this idea of not, so we've been talking a lot about genetics and these different kind of genetic variations and syndromes that are associated with types of neurodevelopmental disabilities. However, when we first define autism or any sort of neurodevelopmental disorder, we're going for behaviors, right? How things look for the clinician. And there's communities where those things might look a little bit different, where the borderline or the boundaries of the diagnosis might be different depending on where you are. And if you do not understand those differences, you might be missing a lot of opportunities to study those folks as well. So this comes from a project. This was just a survey from genomic researchers. And what this figure, which took me hours and hours to do, and I could have asked Tess or someone to do it for me, but I am stubborn. Anyway, what it shows is that this is what was reported for researchers that were doing genomic research across medicine. This is not just in this field in particular. And what they found is their ability to recruit populations from European descent versus people that identified, or because this is all self-identification from any of these ethnic or racial groups. And they were less likely to meet their recruitment targets. Again, this is very biased because it's a group of people that kind of care about this work, that were invested to make it better, and even then they were truly struggling. So most of our researchers said, we really understand what's going on. We have no clue how to make it better. Everybody felt a little bit conflicted about the amount of time and effort that went into creating these relationships. And there was always this question, do we really need to do this? If you have a certain amount of funding and it only goes so much, right? So much further. So if you're using some of that funds to really engage these communities, does it really necessarily translating into advancing the science, if that is your goal? So I think it does. And I want to share, we'll be talking a little bit about a model that we've been using and why I think it's kind of very important. So I shared earlier that there are certain things that we see in some populations that might bias our results. So something, when I started coming to this, when I started working at the Silver Center, as you can tell from my accent, English is not my first language. So I grew up in Peru, and Spanish is my first language, and one of the things I said is like, oh, we're going to translate everything, and we're going to start bringing, more Latinx families. We're in Spanish Harlem, so we started bringing a lot more families that spoke Spanish as their primary language. And one of the psychologists who used to work with us, Michelle, who's an excellent clinician, she made this comment about how the rate of mannerisms, stereotypical movements, was significantly higher in many of these families. And I remember it just led to this conversation about, is there something about the genetics and what we are seeing? And what I've learned, not just here in New York, but then when I've work with families like this in many other countries in Latin America is that we Latinos speak with our hands. So families are just not bothered by it. So they're focusing in other things. So it's not that there was any sort of like genetic predisposition. It's just that families might be focusing on something else. And the reason I share this is that truly if you don't know what you're looking for, and sometimes you need different people to come to you for that, it's very difficult to see. So this guy, Pilar Trelles, he's a visual artist. I don't know if anyone is familiar with him. But he has these like lighting images, and depending on where you're standing, the color of what you're looking will look differently. Sometimes you need like 5 different people looking at one kind of show in order to actually get everything you're doing. And I think that really represents what we need to do when we are talking about genetic social determinants of health and really increasing the reach of the studies we are doing. So, just as other areas of medicine, we do have models that work, like our friends from public health have developed amazing ways to collaborate with communities and bring solutions to places that are really not necessarily well-resourced, and have actually come up with amazing treatments, like what happened with HIV, for example. So we know that if you are strategic and intentional about your collaborations, you find your right partners. You do that if you share resources. That's very important. And the most critical thing is, I personally believe, is truly increasing local capacities. And it could be something as a conference like this, like the Silver Center does a great job at doing this. So it's just sharing the knowledge that we have with other people and just kind of explaining when doing this type of work is very important. Even before we started doing this, and the reason this is here, which seems a little bit off now that I look at it, my first year at CBER, I was very invested. I walk in and I was transitioning from doing mostly clinical, oh my God, again, my picture. Okay, thank you. I lost my train of thought. Okay, I remember. So I was coming from the clinical world. I walk into CBER and I meet, obviously, Joe and Alex, and they're doing this like amazing work. We would spend hours and hours with families. I would get like deep phenotypic characterization. And it was just amazing, and understanding why it was important from a scientific perspective and how it was shaping how we practice medicine and psychiatry. At the same time, across the street, we had a clinic that was under-resourced, and I knew of so many families that were truly even, having a hard time kind of accessing resources. So I met with Alex and Joe when I believed everything they told me was true. I've grown since then. They're laughing. No, everything you say is true. And we decided to do this work with peer advocates. So these were really amazing, like super moms that received that training through the state of New York. Their children with autism were adults. And the training really focused on power empowerment. And I was thinking very naively, oh, of course, I'm going to go across the street and say, hey, there's this research center. They're doing these evaluations that you're trying to get. Just come. We'll do them for free. You need to do my research. Okay, it didn't work like that. So people got very excited, but they were also very worried. And it was, it was very difficult. And a lot of people enrolled, and then we had a huge attrition rate. So we lost a lot of families to follow up. Interestingly, most of the families did stay in touch. And the families that were somewhat related to Mount Sinai were the ones that truly stayed there. So that kind of, came, taught us that, in order to really engage communities, you need to be in the community. You need to form those relationships. You can just not do it from kind of the research lab. And that doing this work and this idea of really trying to understand what is the common goal that you have, because otherwise you can really get lost in the ocean of information that you have. And that's what was happening with many of these families. When they felt the treatment was associated with their with what they were doing for their children, like either seeing their pediatrician or their psychiatrist, then they felt the study made a lot of sense for them. So they could see that kind of common goal. So this image really was just this idea that, if you just look at a tiny little bit of something, you may just get lost in what is like the wider, bigger, more beautiful image. And this is where CBPR, or community-based participatory research camps, again, our friends from public health. Oh, by the way, we started doing this work, talking to families, engaging them, trying to learn from them. I mean, this is a much longer story than what we are talking. And one day, I think it was Paige, is like, oh, Pilar, I went to this talk from this public health person, and you're doing like CBPR. I'm like, what? Like, of course, there's like this whole field of medicine that had been doing this for years and years and years. Because it turns out that if you want to help large communities, you really need to go out there. And there's just people that have been doing it for a very long time. So the nice thing is that we have a lot of information and materials from them. And we just kind of need to be more intentional about how we incorporate them in our work. So this is a figure, also another one that I spent way too much time doing as I was procrastinating not to do something else. But what it says is, here, oh, look at that. Okay, so you have these like shared goals and vision, right? So when you approach any of these families or advocacy groups, you really start from the point of, we all want to help the families and children. And you might be coming from different perspectives. Kind of the clinical goal many times is kind of very, very similar, because I'm a psychiatrist. It's always been about advancing psychiatric care. And obviously paired with the importance of genetic testing. And depending on kind of the research project, you kind of figure out where's the research goal and what are the things that the different research team members are looking for. And then it becomes this kind of iterative process where everybody comes to the research table, you figure out what are the priorities that you have, where do you align, and then you just work around like learning from each other. And there's, it really is based in a lot of conversations, trying to understand what other people is doing. You try to be as equitable about participation as you can. You try to be culturally sensitive, and I think this is not just about like where you kind of come from in the world or what race or ethnicity you have. We are all very different. We all come from very different places. We raise our children in different ways. We live in different neighborhoods. And when you meet and talk to parents, you learn about a lot of things that you are not thinking in the way many of these things affect them in the day-to-day life and what might be more important to measure, right? And then once you're done and you realize that the place where you started kind of sucks, you start again and again until it becomes better. So I'm going to tell you one tiny story. I'm going to try, how am I with time? How much time do I have? Not a lot. 10 minutes? I can't see. I'm getting 10? 12, okay. Now 11. Okay, so very quickly, I'm going to share this story, very close to my heart. So, oh my God, again, my picture. Oh, okay. Did we miss no, okay, oh, sorry. Okay, so this idea of, how do you, engage with families through, forming partnerships. So again, like it's all on the basis of we have this common goal, which is very clear, which is like we want to help children, we want to help families, we want to empower families to be able to better take care of their children. And, this idea of these different tenets, right? So you try to use your resources and you can share them. And communities and families have a lot of resources, so it's not just about the researchers and what we're bringing to them, it's also what we get in kind of in a bi-directional way. Building capacity, trust and transparency, and direct benefit of stakeholders. Okay. So 2016, Joe comes and he's like, Pilar, do you think you can get samples from Latin America for the Autism Sequencing Consortium? And I'm like, of course. I'll just call people. Absolutely, we'll just call and we'll collaborate. I'm sure we'll get like 8,000 samples by tomorrow. Yes, no, that's exactly not how it went. I was very disappointed. Nobody was interested in like talking to me. I mean, they thought it was interesting. We had tons and tons of different calls, but people, like what we were saying, they didn't have the resources. They were really struggling to meet demands of the their day-to-day life, taking care of patients with what they needed to do in that moment, and thinking about genetics just completely escaped them. I eventually connected with this center in Peru. By the way, connecting with people in Peru was even harder than in other places, for whatever reason. But I found the N Center in Sullivan, and they're like, oh, this is wonderful. You can come and see us whenever you want. You can see what we are doing. They had, by the way, they have a wonderful model, but we really do not have time. So I went to see them, and that's where we started to kind of connect. Oh, Alex, those are your legs. Oh my God, no, can you go back? Here, Alex and I went a couple of times. That's Alex, over there. So we went a couple of times. We started, meeting with them. Initially, we went to do like a medical trip. They needed psychiatric care. They don't have the expertise, so we met with a lot of families, provided psychiatric support. But one of the things that happened organically was that we started talking about what we do here, and the families started getting like very, very excited about this. CASP is a center that has been around for like 50 years. Their model is based on power and parent empowerment. So the training, what the treatment model does is they educate the parents so they can be the therapists of their children. And that obviously is more than just giving them the knowledge. There's a lot of empowerment that goes there. So it ended up being this kind of perfect lab to this type of work. We had families that were very, very engaged. We were there talking about this work that we find really cool and exciting. They started to get very excited, and they're like, you know what, we want to do this. We're going to organize our families, we're going to participate of this research, but we needed to do it in a way that benefits us as well. So that's what we did. So we sat together, we said, okay, this is all the resources we have, how can we make it work for everyone? So we work weeks in advance to do this. We went through the consents before we went there. This was a pilot, so we tried to identify the families that really might benefit from the studies. Genetic testing is completely prohibited for most of the families that are there. So there were a lot of children with epilepsy or intellectual disability, that probably would have benefit from genetic testing. So we had a sample that was heavily loaded with kids that generally would have had a very high yield of results. So very briefly, this is what we have. So 100% of our kids were either nonverbal, so they had intellectual disability, they had a lot of socialization deficits, 10 of them had epilepsy. And then we were very excited and thought we were going to have a lot of positive results, and we had just a tiny, tiny bit. And we had a lot of variants of unknown significance, which was also difficult because we had to go back to families and say, there's all of these things that we are reporting that felt a little bit more confusing. So these results kind of highlight why doing this type of work is so important, why the work that we're doing with GALA, with the study that Joe mentioned earlier, is critical because we are also learning, it's not just about what we are learning in the science, but through this project, we've made collaborations and connections with other scientists in Latin America who continue to look at these results, who are learning about how this behaves in these communities, who understand better the social determinants on health. So it's not just about what we are doing and collecting, but about what we are leaving behind and how that will eventually come back to us. And then, one of the things that we really wanted was to give them the benefits. So we did some clinical genetics, and we gave them feedback. There were only 4 families, I think, 3 families that had positive results, but they were all had, talking about personalized medicine, each of them was incredibly impactful and meaningful for the caregivers because of what they were able to get out of it. So although it was a tiny little bit, it really went a long way. So, I want to finish with saying why I keep trying to say that this is not just about what we're bringing to them, but we learn from them. So at this point, 2019, we've been working with SCASP for a while. We had been going, we had gone multiple times. We really knew they had this wonderful program to support families. But we really, I don't think I truly internalized how impactful it was what they were able to do for the families. So when the COVID-19, hit and all the schools closed, and all of a sudden, all of the therapies were going remote. Many of the parents had never been necessarily directly involved in the care of their children. We started seeing a lot of kids truly going through a lot of, kind of a regression, huge increase in behavioral difficulties, and obviously most of, the parents were like, really anxious and depressed. And paradoxically, in the school in Peru, where, by the way, there was like the highest mortality rate in COVID, the kids were doing great because, they were with their families, nothing had changed for them. Their parents really knew how to support them through this time. So it came the idea, and we had, here we had a number of Latino families we were working, and they were truly struggling. So it came the idea, so we applied for a pilot with a number of my colleagues from CIVER, and we said, why don't we enroll a number of these Latino families in New York City, in the school in Peru, in the middle of the pandemic. And I think because it was the pandemic, they let us do it, because people here get very scared about like licenses and where you practice. Anyway, we were able to do it. And so we chose a period of time that we thought we could see some change. CIVER, we were the research side, we collected all of these different outcome measures, and the intervention was being delivered remotely from Peru. The only thing we needed from families were that one of the caregivers spoke Spanish. None of the kids spoke Spanish, or very few of them. They understood it, but it was not their first language. But it worked well. We, enroll about 30 children. Both of the groups were the same. I was going to show this, but I don't think we have time. So I'll just pass it. But anyway, this is really how it was. Families, this is done in a naturalistic way. So what the model does is it uses kind of day-to-day activities in the house. So it's not taking away, parents still need to like clean the house and wash dishes and make beds and get their kids ready for school. And so they use all of those activities as a learning classroom, and it's about teaching the children to gain skills that make them independent in life, depending on wherever they are, and making sure that parents have the skill to guide them. And a lot of, initially they just work on things like, I know it's very, we understand it's extremely frustrating, or you are, you need to get out of the house and your child is taking 45 minutes in putting the shoes on. So a lot of the initial work is working with moms, most of the times with moms, but also that, in kind of, being patient, kind of building up this like, hey, you can do this, and things like that. So we were extremely successful. I was...
I'm going to wet the sponge.
Okay. Because I don't think we have time to see this. We can go to the next one.
Soap.
Okay. We actually saw improvements in a way that I really was not expecting. So we saw improvements in kids, mostly externalizing behavior, so hyperactivity, aggression, irritability, self-injurious behaviors. We saw improvements in adaptive functioning, especially around socialization. One of the things that parents reported, kind of when we spoke with them, rather than in these surveys, was that they felt they actually understood what their kids needed in different times, and they were enjoying their time with their children a lot more. It just didn't feel they were not like constantly stressed about not knowing what to do with them. we saw that caregivers, so at the beginning of the study, most of the caregivers, again, this is the middle of the pandemic, so very, very difficult time, they had clinical scores for depression. 16 weeks later, almost none of the moms that were part of the study had depression. They were still very anxious. It was a global pandemic, but the depression was significantly better. And this is one of my favorite results, which was the most significant, which is around family empowerment. And the different systems is just how much moms, again, like they were all moms in this study, felt they could actually, navigate the needs of their family at home, of their community, and how much they felt they could advocate for their children outside the house. And that was very significant, and it was a very short period of time. So I'm going to also, I wanted to put this, but we don't have time. Also, it's in Spanish.
La experiencia con Nueva York realmente ha sido maravillosa. Me ha permitido conocer diferentes tipos de cultura. El idioma no ha sido una barrera, ha sido algo que al contrario hemos sabido aprovechar, y en otras situaciones pues no ha sido una limitante tampoco para aprender nuevas.
Okay. She says it much better than I would ever say, but basically what she shared is, her description of this project and what she learned from our families in New York, although, again, we were kind of bringing something to them, but just being able to do this in a very different setting, different cultures, different type of words for in Spanish, really kind of also gave them a lot more that allowed them to integrate and improve some of the things they did with families in the original model in Peru. So I think it kind of brings together what I hope I've shared, and I hope it's helpful for you, which is, doing this is important for a number of reasons. And we all have a lot to teach each other, and I think as a scientist really need to stop, or clinicians to stop and really learn from families, because that's the only way where we'll really be able to kind of advance science in meaningful ways. And while this was hard to set up, there's a lot of iterations and variations of this. The study that we're doing in Latin America, now we have a network of people in different countries. We've done very similar work in now 3 cities in Colombia. So kind of once we figure something which is kind of quite obvious, again, like if you go to families and say, hey, I really want to help, but I need to learn from you and figure out where you are, and you meet them where they are, they really want to work with you. Like everybody kind of wants the same. And when we fail at doing that is, I think, when we kind of make like significant mistakes. So I think we all need to share. This is not just scientists, this is not just the clinicians or the funding agencies. It's the share that also kind of families and advocacy groups have in moving us forward. And that's it. And, oh, no, that's not it. This is all the people. There's a lot more. But, so thank you, everyone.